Hello everyone and welcome to the second part of the SAM discussion, and today we'll discuss something about management of SAM patients. And if you like my effort, if you like my previous video, and if you like this video, please go down below and press the subscribe button, press a like, and please share it to your friends to whom it might be useful. So management of SAM. Management of SAM child would begin as ABCD: airway, breathing, circulation, and decontamination, or dextrose. Here the D stands for dextrose. So hypoglycemia becomes a very important component over here. For our own convenience, the guidelines have very aptly and easily determined for us the 10 steps for management of a SAM child. So we'll go one by one for the each step of the treatment, and that is what will help us remember. Initially, we begin with the step one. Step one is management of hypoglycemia. So you have to remember that the SAM children have very less protein and fat stores, so they are very likely to go into hypoglycemia when they are pushed above the cliff to sepsis by sepsis. So you have to be very careful that to manage the child and always anticipate hypoglycemia. The step two is treat. We'll go into each of the steps individually and see the treatment, but first we'll enumerate all the steps. So treat hypothermia. Hypothermia is again a very important aspect, because as you know that you need fat and you need homeostasis to maintain the temperature of the body. But here we have a lack of that, so that is why this happens. The next one is treatment of dehydration. Then the fourth step is electrolyte imbalance management. Step 5 would turn out to be infection. Treat infection. The step 6 would turn out to be correct micronutrient deficiency, like all the vitamins mainly and other electrolytes. Step 7 would be start cautious feeding. Again, go slow. Do not, I want to treat the SAM child in a week. Don't do that. Take your time. Start cautious feeding. Slowly grade up as the child tolerates more and more. Then 8, 9, 10 are the steps that you can also give in the home-based setting. So 8 is rebuild the wasted. So catch up growth. The growth that the child has lost, we have to catch that up. Loving care and play to the child. And the last step is follow. That is the most important. Sometimes what happens is we treat the SAM children, they go home, they come back again SAM. So you have to be very careful that follow-up is again very important. You have to give them a clear-cut timeline of when they have to visit the hospital and what care should they take. And again, you have to prescribe the appropriate treatment for the patient when they go home. So we'll begin with step 1, hypoglycemia. So hypoglycemia is defined in a SAM child when the RBS is less than 54 mg per deciliter. So in a patient of hypoglycemia, if the RBS is less than 54 milligram per deciliter, you have to determine it, and it can be divided into two, that the child is conscious and the child is unconscious. So if the child is conscious, you can, if the child is taking well orally, then you can give 50 ml of 10D orally, D10 orally, and start the F75 feeding henceforth. So that is what you do if the child is conscious. And if the child is conscious but not being able to take the feed, then you can put a infant feeding tube or the rice tube according to the age, and then you have to give this 50 ml of D10 orally again, and then start F75 feeding if the RBS is normalized. Now, if the child is unconscious or does not take orally, or the child is seizing or anything, you have to give 5 ml per kg D10. And once the child becomes accepting or child becomes conscious, again give orally and then start F75 feeding for the child. Do not take too much time, and all the management should proceed together. You should not wait for one thing to correct and then start. Everything should be started parallelly. Do not wait. And again, to prevent hypoglycemia in a already indoor child, please make sure that the child is taking night feeds. Sometimes what happens is the night feeds are missed, the child is not woken up, the child does not take night feeds, and the child will be in hypoglycemia early morning, or it might even die in his or her sleep. So you have to keep in mind. Hypothermia. So hypothermia, again, we will divide it into two parts. That what you have to do if the temperature. See, first you have to, you see the hypothermia, we take auxiliary temperature, and have to take at least for 3 minutes, for the, the mercury to settle down, or the temperature, or if you take digital, then you have to take till the beep. But if you are using a mercury thermometer, then you have to wait for at least 3 minutes for the mercury to settle down at a good level to recognize the real temperature. So if the temperature is less than 35 degree to 32 degree Celsius, and if temperature is less than 32 degrees Celsius. So again, as I told you before, you have to assume that the child might be in sepsis, but for firstly, you have to put child under warmer if you have. Be careful not to overheat and be slow. Warmer, overhead warmer might be used, open system or incandescent lamp or bakery bulb. So you can do that, and you can or you can advise the mother to wrap the child and give KMC like management, that you have to wrap the child in clothes and body to body warm, body to body heat transfer. So that also can be given over here. KMC like management you can give, and you have to monitor every 30 minutes. And again, that if there is no improvement or there is further fall, then you have to go into the second management that we are looking over here. So if you are having less than 32 degree, then you have to give 5 ml per kg bolus of 10D, because it might be hidden hypoglycemia. Bolus of 10D. Give oxygen if there is cyanosis or respiratory distress, O2, but be very careful to give humidified O2 and already warmed. And here, if you give saline, give pre-warmed IV, pre-warmed IV. Do not put it out from the fridge and give it to the, because it worsens the hypoglycemia. So you have to be very careful. You can use a overhead warmer over here too. And start feeds as soon as possible. So the child acquires his own ability to fight off the hypothermia and maintain the homeostasis. So this, and again, if the child is in dehydration, then treat dehydration. Treat dehydration. Again, the mother needs to be counseled about hypothermia and advised about keeping the child warm. She should be advised that the child's clothes should be changed if it is wet, or if the child has urinated, bed sheet should be kept dry, and maintaining the room temperature by closing the windows, and there should be no drafts of air coming from outside, and covering the child, especially the head portion of the child, is very, very important. And feeding on time is very, very important, because again, hypoglycemia causes all this. Now next is management of dehydration. So for SAM child, the conventional signs of dehydration are not present. This is step 3. So conventional signs of dehydration, like skin pinch going back very slowly, or dry mucous membranes is already present in the SAM child. So these signs are not reliable. So how do you determine that the SAM child is dehydrated? So it is very, very important to fulfill at least these things, that you can say that there is a significant history given by the mother of diarrhea, significant history, or mother gives a significant history of diarrhea, or mother gives a significant change in appearance. Significant change in appearance, that the mother says, no, today the eyes are more sunken than before. So see, this is a very, very it is based on history. That if the mother says that there is a significant history of diarrhea, there is significant history of loose stool, there is significant history of change in appearance, then you have to assume the child has dehydration and not assume otherwise. So for SAM, the classification is something like this: AGE, acute gastroenteritis without dehydration and with dehydration. Okay. So for without dehydration, again, we can give Resomal, we can give ORS. Resomal is rehydration solution for malnourished, not reduced osmolarity. ORS, it is Resomal is reduced, it is not reduced osmolarity, it is rehydration solution for malnourished. So with dehydration, now if there is with dehydration, then you have to see for shock. So if it is without shock or with shock, see, conventionally AG is determined that some no dehydration, some dehydration, severe dehydration. For SAM, this is a different classification that you have to remember, that without dehydration or with dehydration, and without shock, with shock. Now, if without shock, to give 5 ml per kg ORS from RT every 30 minutes for at least 6 to 8 hours. Okay, and after 10 hours, you can give alternate feed, and you have to start F75, because again, ORS is, does not have enough dextrose to fuel the body's metabolic rates. So then you can, once the child is stabilized after 2 hours, for the first 2 hours, you give 5 ml per kg for first 2 hours, first 2 hours, or first 2 hours, followed by 10 ml per kg ORS hourly for 10 hours. So, but then you have to, alternate it with F75, because again, if you calculate the dextrose content in ORS, it is lesser. So this is how you have to manage. If there is no shock, but the child is dehydrated, do not give boluses. Absolutely do not give boluses. Start ORS orally, and the child will improve slowly and slowly and slowly. Now with shock, what you have to do is you have to give 15 ml per kg bolus of either half DNS or RL or NS. You can give 15 ml per kg bolus over 1 hour. You have to give, and then reassess. Reassess. Now, when you reassess the child, there is improvement or there is no improvement. Improvement present and improvement, no improvement. Okay, so if the improvement is present, give another bolus, another 15 ml per kg bolus over 1 hour. Okay, and once that is completed, shift to ORS. Okay, and if there is no improvement, assume that the child is, assume it is septic shock. Assume it is septic shock and start dopamine or noradrenaline according to guidelines, and assume that it is septic shock. Please, do not miss the golden hour of antibiotic. Give the antibiotic in the first hour. So assume it is septic shock. Do not give more boluses. Again, at any point, if there is tachycardia, if there is pulmonary edema, see, ideally what happens is when you correct the dehydration, the heart rate should not increase more than 15, and respiratory rate should not increase more than 5. So if it is more than this per minute, you have to assume that the child is going into pulmonary edema. So that might be overhydration. There might be overhydration. So at that point, you have to stop the bolus and go to the directly the management of septic shock, because again, overhydration does not help. And after the first bolus, what you assume is that in unconscious child, the weight should increase by at least 7%, or in a conscious child, 5%. So that is your target. If that weight is achieved, then it is very good. If the weight is going over, then you have to suspect that again there is overhydration. So you have to be very careful of overhydration, and you have to assess the patient. Now, ORS is again very important. ORS will improve the patient. And for shock, you can use the CRT on the nail bed, capillary refill time on the nail bed, and that would help you assess the degree of dehydration and what are the markers that you have to see. Next is electrolyte imbalance. You have to correct imbalance. So you have to give pot chlor, potassium, to give 3 to 4 milli equivalent per kg, and in pot chlor syrup 15 ml is 20 MEQ. So there are readily available charts on how much pot chlor you have to give according to the weight of the child. And magnesium sulfate for the first day it is given as IM, and for the rest of the 13 days you have to give orally. The same injection can be given orally, and it is 50%. The concentration is 50%. The dose is 0.2 to 0.3 ml per kg. ml per kg up to 2 ml. So that magnesium sulfate is to be given. So these are the two electrolyte imbalance that you have to correct first initially, and you do not have to wait. Antibiotics, next step is treat the infection. Antibiotics. So the choice of antibiotics is MP-Genta, ampicillin gentamicin, or you can give ceftriaxone Genta, or you can give Piptaz alone. If you are suspecting meningitis, give cefotaxime or ceftriaxone, depending upon the sensitivity and the availability and the age of the child. So you can give cefotaxime or ceftriaxone, and if there is dysentery, give ciprofloxacin. Ciprofloxacin you can give in dysentery. So that is what you have to give. Dosing 50 mg per kg for MP, 7.5 mg per kg for Genta. See, all these doses are mg per kg. I will not mention it again and again and again. So for this, let's take it over here, mg per kg. Ceftriaxone, gentamicin, again ceftriaxone doses 50 mg per kg. Ampicillin BD, ceftriaxone is also BD. Gentamicin is OD. Aminoglycosides are always given OD, and Piptaz you can give 75 to 100 mg per kg. 75 mg per kg you can give QID or TDS. And for cefotaxime, you have to give 50 mg per kg QID. For meningitis, if no meningitis, then you give it TDS 3 times a day. Ciprofloxacin that is given for dysentery is 10 mg per kg BD. So that is the fixed dose of ciprofloxacin. If there is a severe case, you can give ceftriaxone, metronidazole. So these are the antibiotics. For meningitis, you have to give at least 14 to 21 days of antibiotics. If culture positive, 21 days. If not positive, 14 days. And if culture positive sepsis, give at least 14 days of antibiotics to the patient. And UTI, if UTI is present, then give 7 to 10 days. So these are the basic infections that we see in SAM, and you always have to rule out 2 diseases in SAM, that are tuberculosis and HIV. Please do not forget them by any means. And if there is corneal ulceration, you have to give vitamin A. Vitamin A less than 6 months, 6 months to 12 months, and more than 12 months. So 50 kIU, 100 kIU, and 200 kIU. So this is 0.5 ml, this is 1 ml, and this is 2 ml. This is the dose you have to give at 0 or 1, 2, and 14 days. 3 times you have to give this vitamin A dosages to the children, and the child will improve. Next are the micronutrients. So we have seen vitamin A. Other micronutrients that you have to give are folic acid. Folic acid you have to give 5 mg on day 1, followed by 1 mg every day. 1 mg daily. This is not mg per kg, this is just mg. Zinc you have to give 2 mg per kg per day. Copper 0.3 mg per kg per day. But if copper is not available, then what you can do is you can make food in copper vessels. It would be very, very helpful again for Wilson's disease. Do not prefer this. And iron, you have to start after at least 1 week. It is 3 mg per kg, because again, iron, worsens the infection. So you have to be very, very careful and not, start it very rapidly. Now, for feeding, as you know, initially we begin with F75. We begin with F75. We give it 2 hourly. For smaller, we give, because there is decreased tolerance. So if we have to divide more frequent feeds in less volume, so that the child might tolerate it very well. So for the first day you do 2 hourly. Then if child takes it, then make it 3 hourly. Once it is 3 hourly, you can shift it to F100. So that you have to, slowly grade up the food. Now for F75, there are 2 types. One is cereal based and one is non-cereal based. So for cereal based, we use the puff rice, or in local language called as mumra. Now, during making of F75, we put all this mixture into the oil, and not oil into all this, because there is improper mixing. So first we put the oil, and then we put all the mixture of puffed rice into this, and the peanut paste. There are also egg based and chicken based diet, but that will not go into this initially. So now what happens is, if you do not mix the mixture properly, what happens is that if the oil does not get mixed properly, then some children would get higher amounts of high density or high caloric density food, and some would get low density food. So to be very, very, very careful to mix it properly. If you do not mix it properly, some child would get more oil, some child would get less oil. So that is what you have to keep in mind. The total volume every day, you should measure that how much the child. You can begin with 90. You can begin with 80, 90 ml per kg per day, and you can grade it up to 120, 130, depending upon the intake the child has. If the child starts vomiting, or the child has no intake, then you should stop, and you should make it more frequent feeds. Smaller volume, more frequent feeds. And for these more frequent feeds, you have to wake the child up in the middle of the night and give the feed to the child, or else the child will go into hypoglycemia. Now, for patients who are unconscious or who are not accepting the food, you can put the rice tube, and you can give the management accordingly. Now, for the rehabilitative phase, you have to give the catch-up diet to the patient. Now, catch-up diet to the patient can be given after the starter diet from the 3rd day, and you can give freely to the child. And the frequency of the feed should be decreased as less as either 6 times a day or 4 times a day. So once the child only eats 6 times a day or 4 times a day, you can consider that yes, the child is taking orally well, and we do not have any concerns. Now the child will take the food very well if the child is given. And along with that, we have to give love and caring to the child. You should be very, very you should interact with the child, you should play with the child, you should make the child feel involved. You should give effort to the child, so that once the effort is made, the child grows, child has improved development also, and the growth is present. So that you have to be careful about. Again, I'll remind you that night feeding is very, very involved, and at the end, before you give discharge, you have to involve the family members and mothers into the management of child. You have to teach the mother what to feed, when to feed, how to feed, what are the proper dilutions, what involvement should she have in the feeding of the child or development of the child. So gradually, once the mother learns, the family member learn, they learn to take care of the child properly. And once they take proper care of the child, then the child will gradually improve. Regular follow-up is very, very important to the child, to monitor that in what direction is the weight going. Again, that you should be very careful that once, if you do not have proper follow-up, the SAM child that you have, improved will come back as a SAM soon. Again, Government of India is doing tremendous and extremely good efforts in management of SAM children. And at the place I work, we have a 10-bedded SAM corner for the children, and that is what we usually have a lot of patients, and we have around 25 patients every month. So this is a holistic approach towards the severe acute malnutrition of the children, and you should be involved in this. This is, pediatrics is not only about treating sardi, khasi, bukhar or ICU management. It is this also, and the management part is very well defined by the government of India, and we take inspiration from them. So I guess that's all for today, guys. I hope you like the video, and if you like the video, if you like the effort, please give a thumbs up and subscribe to the channel, and see you soon. Bye bye.